Welcome. My name is Nick Butler. I am with the Department of Family Medicine at the University of Iowa. I'm a geriatrician and family doctor, and today I'm going to be giving you an overview with some focus really on frailty and then cognition and mobility as part of the 2018 Geriatric Lecture Series. This series is funded by the Iowa Geriatric Education Center as part of the Geriatric Workforce Enhancement Program through HRSA. I have no conflicts of interest, financial conflicts of interest. I have no ties with industry or manufacturing. I have no financial relationships with any companies supporting this educational event. I will not discuss any pharmaceutical, medical procedures or devices that are investigational or unapproved by the FDA. The theme for the 2018 lecture series is dementia, mobility, and disability. My objectives for today is to help you learn to identify frailty, learn to treat and really understand the clinical impacts of frailty, and then at the end of the second portion of my talk will be discussing the relationship of cognition and gait. I think frailty as well as this idea of cognition and gait are very important, as I think they are all related to mobility. And so let's go ahead and get started with frailty. So what is frailty? And I want you to take a moment to maybe pause the podcast, and I want you to write out and commit to a definition of what frailty is, what you think it is. So I'll give you just a moment to do that. So what is frailty? So frailty, as defined in 2001 by Linda Fried and her group, is a biological syndrome of decreased reserve and resistance to stressors resulting from cumulative declines across multiple physiological symptoms and causing vulnerability to adverse outcomes. So what does this mean in layman's terms? Because that is a fancy definition. I think it's important that you don't think of frailty as that thin, older woman, because an overweight male or female can be arguably more frail than that thin woman. And so I think it's important that we get away from that kind of, it looks frail approach to diagnosing frailty. Really what this is if you think of cardiac reserve or pulmonary reserve. So we have what we normally need to get by in day-to-day life, but then we've got that extra reserve of lung function or cardiac function when we're under stress or we're exercising, and that's there. Okay, think of that in the same context as the individual then. So the individual has what they need to get through life, and then they've got this idea of reserve. And this reserve is built across all the organ systems, musculoskeletal, nervous system, cardiac, and so forth. And what frailty is its loss of that reserve, so that any adverse event that comes along, maybe it's having to walk up a flight of stairs or just step up a curb, maybe it's internal stress like a pneumonia or a heart attack. These individuals who are frail, because they don't have that reserve, end up with poor outcomes. And if you think of it in that construct, I think that's the best way to frame it. This is a complex definition, but I think if you put it in this idea of reserve, it'll help make you understand a little bit better. So features of frailty, the two hallmarks of frailty are weakness and fatigue. But we also see weight loss, decreased balance, low level of physical activity, slowed motor processing, social withdrawal, mild cognitive changes, and increased vulnerability to stressors, as I described earlier. Now, frailty is multifactorial. There isn't a unifying pathway to get to it. So there are physiological factors, social factors, and then biological factors. So the psychological factors would be like depression or cognitive impairment, anxiety, things that maybe keep people from being as active and being engaged as they otherwise would be. Social factors are environmental. Maybe they live in a place where they can't get out and walk. Maybe they live in a place where they can't have quick, easy accessibility to protein-rich foods. Maybe they have a poor support system. Biological factors then are genetics, motor unit recruitment. So this idea that lifting a feather compared to lifting a boulder, you need more motor units to recruit in order to do that, and the ability to recruit more motor units in some of these individuals might be impaired. Hormone dysregulation, we think, may have a role. Vitamin D, cytokines, so certain inflammatory markers, and interleukin-1 or IL-1 has been implicated in this. And then disease, in terms of chronic diseases such as chronic lung disease or heart disease or such. And the combination of these kind of three major pillars then is what leads to the frail condition, which leads to functional deficits and decline, which leads to hospitalization, subsequent institutionalization, and death. And I actually think that the loss in IADLs can actually occur earlier, before the onset of frailty then as well. So it's a complex pathway, but we do think that the unifying piece to it is this idea of sarcopenia. So sarcopenia is the pathological loss of lean muscle mass. And so this is different than what we normally see in aging. So in normal aging, there is this transition from lean muscle to more adipose tissue. We know that. But this is loss of muscle mass because the cardiopulmonary system, for example, can't support that amount of muscle in the body. The protein in the diet can't support that amount of muscle in the body. Inflammation leading to breakdown of the muscle. So it's multifactorial, but we think the sarcopenia is a large component to this. Now, frailty is not like other diseases. It's not like high blood pressure and diabetes, where we have clear kind of clinical cutoffs for, for example, high blood pressure, 140 over 90 as being the diagnosis for high blood pressure, or diabetes mellitus type 2 with the hemoglobin A1C of 6.5. We don't have that. And take diabetes, for example, that is we think, right, because of the insulin resistance, that's what leads to diabetes. It's a more linear approach to what leads to the disease, where it's multifactorial with frailty. And so frailty falls under this idea of geriatric syndromes. So a syndrome is a group of signs or symptoms that characterize a specific disorder. They're inherently multifactorial in their origin, and there isn't a single common pathway to the disorder, so everyone is going to experience the progression to frailty or a geriatric syndrome differently. And below is a list of examples of common geriatric syndromes. So when should you think about screening for frailty? And I think you probably should have several of these before you screen. So age greater than 65, multiple chronic medical problems, an admission to a long-term care facility, osteoporosis, osteoarthritis, rheumatologic disorders and autoimmune disorders because of the inflammatory nature of those, chronic kidney disease, chronic cardiac disease, dementia, and then polypharmacy. And polypharmacy can be a bit of a more difficult number to figure out. Some people would say 2 medications is polypharmacy, others would say 18. I think 5 would be a good place to start. So if you're age greater than 65 or younger than 65 with a lot of comorbidities, then I think it'd probably be wise to screen for frailty. Another way of thinking about when to screen for frailty is this was a study that looked at living space. And so if you think of the hub or the center of that living space being the bedroom or the individual's bed, and how far away from that bed can the individual get on a daily basis? And then you look at that as a radius. So can they get out of their bedroom? Can they get to their living room? Can they get outside the home? Can they get clear across town to run errands? And how often are they able to leave their immediate neighborhood more than 4 times per week? And if they were unable to do that, then women who are unable to leave their neighborhood less than 4 times per week had a 1.7 times more likelihood of becoming frail. And this was this was regardless of their mobility, their IADLs or their ADLs. So independent activities of daily living, activities of daily living, did not change this living space. So what that means is people who have, say, a spinal cord injury, who are, wheelchair bound or motorized wheelchair bound, if they're able to get outside of that neighborhood 4 times per week, then that was a good indicator that they're unlikely to become frail. Or someone who may otherwise look fine, look like they're able to get around, but they don't really leave their neighborhood, those are the ones that maybe you should think about screening. So it's this idea of this living radius, and it's not easily captured in the clinic. So fixed distance and fixed time testing, like the time get up and go test, aren't good measures of this. So there's 2 schools of thought for screening. The first is put forth by Rockwood, and this is this idea of a frailty index. The second was put forth by Linda Fried from the Cardiovascular Health Study, and this is an idea of a measurable phenotype. So Rockwood's idea of a frailty index was that it's a 70-point scale, and it's an accumulation theory. So with enough chronic disease, enough disability, so diabetes, swollen legs, incontinence, whether or not they're able to make telephone calls, and enough deficits and enough chronic disease at a point, then is when frailty kind of shows up. Now clinically, that's difficult to apply, as you can imagine, and so there wasn't great uptake of it, but I do think that it does have some value, and there are similarities with the Fried scale in some respects. So the frail phenotype is a measured physical characteristics that look at 5 criteria to determine frailty. So it's walking speed, unintended weight loss, recreational calorie expenditure, fatigue, and grip strength. And there is normative data for walking speed, normative data for grip strength, based off of gender and size and such. And if they meet that criteria for that specific category, so for walking speed, then there's a point given. And the nice thing about this is that it gives a frail, pre-frail, and robust categories. And the frail group is if they qualify by 3 or more of these categories. Pre-frail is 1 or 2 of these categories, and the robust or non-frail are if they trigger on none of these categories. Now this can be operationally difficult though too. You need a place to be able to measure walking speed. You need the normative data, which they did publish in their study, but you do need the normative data for that. Recreational calorie expenditure can be a challenging thing to calculate because you need to take into account what the physical activity is of the individual, how much time they're spending doing it. So it's knowing the details. So the individual may be a runner. Well, at what rate do they run, and how long do they run at, and how many times a week do they do it? And you add all of those things up. So it can be logistically challenging, but it gives a good baseline of kind of physical measures for frailty. It has become the gold standard, it seems, when it comes to assessing frailty from a research standpoint. It's measurable, it's objective, and it seems to correlate well with patient outcomes. But like I said, it's clinically intensive, and that's the downfall of it. Now, a lot of studies have looked at one frail scale compared to another. And I gave you examples of 2 of them. There are at least 20 out there, and this one carries well compared to others. One that is more maybe clinically relevant is called the Frail Scale, developed at St. Louis University. And it takes 30 seconds to complete, and it can be completed by the patient. Again, it looks at 5 criteria: self-reported fatigue, can the individual walk up a flight of stairs, can they walk several blocks, do they have more than 5 chronic illnesses, and have they lost 5% of their weight in the past 12 months. 30 seconds to complete. I think that's pretty useful for primary care. And if you look at frail, fatigue F, resistance R, Aerobic, the walking the blocks. Aerobic is the A, the illnesses is the I, and then the loss of weight is the L. So it makes it an easier primary care tool, and when it's been studied, compared to the Fried scale or the frail phenotype, it seems to function as well. So this is an example of a scale that we have adopted in our geriatric clinic at the university here. We do the Fried or the frail phenotype, and we also have this one available. This is the frail scale operationalized, and we've actually included a clock draw on the bottom as a way of measuring cognitive function then as well. And that was not initially included as part of that scale, but we do think that there may be some relationship here between frail and cognition, and that's why we've included that. And I'm going to actually speak on that a little bit more when I talk about cognition and mobility on the second half of my talk. So what are we really trying to find here with looking for frailty? Well, we're trying to find the most vulnerable people, the people who've got chronic disease and disability who are also frail, and trying to identify those people so we can help them. Well, why is it important to identify the most frail or the most vulnerable? It's because we find with these people who have frailty that there's normal fluctuations day to day in terms of how well they function, how well they perform. And you and I experience this then too. Okay? And when you become acutely ill, there's an abrupt decline of functional and independence. And for most of us, we don't dip below the kind of the dependent functional line. But for the frail individual, they may likely dip below that line where now they're a dependent adult in terms of their need for assistance with activities of daily living. And what's interesting is the frail individual, once they recover, they don't get back to their baseline. And so if they take several illnesses in a row, now suddenly they're permanently below that dependent functional line. And that's where they need institutionalization. So it's trying to find these people who are pre-frail earlier on in the course and try to intervene there, because maybe there's a way we can put this off and prolong it. Now I think it's important to consider some maybe disease-specific relevance for frailty. And so this was a study that looked at frailty and survival in end-stage renal disease patients. And you can see at the 1 year time point, the frail and the non-frail were about at the same level for mortality, about a 10% mortality. But at 3 years, the frail and the pre-frail were at a 40% mortality, where the mortality rate for the non-frail, it almost plateaus at 15%. And so identifying these pre-frail and frail individuals before they start dialysis, at the very beginning, and then screening for it throughout, might help prolong their life. Frailty in cancer survivors, the non-frail is the top line, the frail is the bottom line. And you look at the mortality at 5 years for the frail patient, mortality is upwards of 70%, where survival is upwards of 80% in the non-frail. Now at 15 years, there's still a substantial difference, but the rate of decline in the frail group is far more severe. So again, trying to identify these people sooner and trying to intervene on them. Again, this is a 2015 study. This is an evolving science right now. The individual components of frailty then, so grip strength, for example, and then looking at mortality data. So case fatality rates for inpatient diagnoses of myocardial infarction, stroke, cancers, etc. The lowest third performers in grip strength across the board had higher case fatality rates. And so again, it's trying to identify these people before they become sick as a means of trying to intervene on them. Again, a 2015 study in Lancet. This is a study looking at ICU survivorship, a 2015 study. And just all comers at the top left graph A shows the robust versus the frail patient. and an absolute mortality difference of 6% in those aged 80 to 89, and an absolute mortality difference of 9% in those 90 and above. So again, identifying these people early and trying to intervene. And also, for those of you who maybe do a lot of ICU level care, knowing that an individual is frail coming in might change or alter your goals of care discussion as you see the progression of the individual through time. Then the other graphs look at cancer and cancer with frailty being the gray line in box B. But box D then I think is the interesting one with cancer, chronic organ failure, and frailty versus cancer with chronic organ failure. And again, a pretty wide spread between those groups. So I think it has some significant mortality projection once an individual becomes frail. So let's say you don't care about clinical outcomes. Let's say all you care about is the dollar bills. I think I've got some data for you too. So with Medicare beneficiaries, they looked at what percentage of certain patient populations were at risk for becoming high cost. Okay, and so on the far right of your screen is those who are relatively healthy. So the 70-year-old who really doesn't take any medications, versus those with simple chronic disease such as high blood pressure, and then minor complex chronic conditions such as diabetes, major complex chronic conditions such as kidney failure or heart disease, and then they looked at end-stage renal disease in people under the age of 65 who were also disabled, and then frail elderlies. And the frail elderly group, they had a 46.2% likelihood of becoming a high-cost patient. Compare that to essentially the next sickest group, those under 65 who are on dialysis or on disability, only 14.3% likelihood of going on to become a high-cost patient. So a substantial difference. So a high population of this group is going to become high cost. Now the average cost for the frail elder patient per year is $70,000 a year. And that's second only to those who are on end-stage renal disease. And you can see across the other groups, those high-cost groups are at a much lower percentage compared to the rest of the cohort, and their costs are fairly uniform. So what's interesting is that there's such a high probability of these frail older adults becoming expensive, and once they do, they stay expensive at a much higher cost than as well per year. And what's interesting with this group is if you look at the midpoint there of the price breakouts, the frail group has $24,000 per year for post-acute care and $23,000 for inpatient care, which is above, and specifically the post-acute care, that's head and shoulders above any other group. And then I just take a step back, and I don't have the data on this, but I wonder, with the inpatient care, with the skilled care, how many of these individuals then become institutionalized at a very high cost until the end of their life? And so what can we do to modify this? Because if you think about the baby boomers that are coming, I think we're going to learn more about frailty as this group ages, but we're also set to have an explosion in cost as this group inevitably develops a large frail cohort. And I think we can extrapolate costs better for heart disease and chronic kidney disease because those are fairly stable as a percentage across the population, and we can project where those things are going. But frailty as an evolving thing, that's something we don't really know as much about. And so what's this cost going to escalate towards in the future? I don't think we can extrapolate that data as well. And so trying to identify this early and soon may be very helpful for long-term cost control. So the medical evaluation. So we've identified it. We understand the clinical significance of it. How do we evaluate it? I think Doing a thorough evaluation, looking at thyroid function and screening for anemia, vitamin deficiencies, blood pressure issues, infections, GI issues, a geriatric assessment. I think these are all important steps to the medical evaluation for frailty. I think a comprehensive geriatric assessment is important, and it's because we're trying to optimize disease burden while minimizing polypharmacy and also screening for comorbid geriatric conditions, because if frailty exists, then maybe dementia exists, maybe depression exists, and maybe treating those things helps with the frailty then as well. So treatments for frailty then, so resistance training has good evidence with regards to reducing falls, increasing muscle strength, improving quality of life, reducing pain, and improving functional independence. Part of the issue with this, though, is that if you stop resistance training, the benefits can be lost. Psychosocial interventions is screening for treating underlying mood disorders using a geriatric depression scale, which is seen up in the right-hand corner there. I think the short form, the 15 question, is sufficient for screening. Tai Chi and functional training can be helpful for balance and strength. Be also helpful for socializing these individuals, as we think that can increase socialization, can be an important contributor for helping treat frailty. Nutritional support is important. An additional 18 to 26 grams of protein, so 20 to 25 grams of protein a day is helpful, as is vitamin D replacement at 1,000 international units per day. But once support is stopped, benefit is lost. So there is some limitations with that. This was an algorithm developed at St. Louis University through the Gateway Geriatric Center on Aging, again another GWEP or Geriatric Workforce Enhancement Program funded institution. But it walks you through the individual components that we think make up and contribute to frailty that we're screening for, and how to medically evaluate each one of those things and deal with each one of those areas. And I personally have this hanging up in my geriatric clinic because it helps me walk through and just be methodical in my approach to dealing with this. This is one of the few studies that's out there to look at kind of post-intervention, and this was in COPD patients and looked at pre and post-rehab. And as you can see, the percentage of frail patients after rehab, it went from 20% of their group being frail to after rehab about 5 to 10%. And then the robust group, it went from about 10% upwards to 25%. So we think that these interventions are helpful, and it seems like even just getting people up and moving with something such as pulmonary rehab might be sufficient to help with this. So the research is just now coming out and being worked on in terms of these interventions. So I think the next few years are going to be quite exciting for understanding frailty. So frailty, just to kind of recap things, I think you should think about it in your older adults. I think you should screen for it in those who are at risk, and I think we should all work towards treating it. Don't forget to assess for the other geriatric comorbidities, but I encourage you to respect frailty. I think it has significant morbidity and mortality data with it that once we identify it, it really should change our scope for how we help counsel our patients with what they do. Now I'm going to switch gears, and this next section is much more kind of research study based, and a lot of it's because the research study is kind of actively being looked at. And this is the relationship between cognition and mobility. So one of the early studies that looks at cognition and mobility was from Lancet in 1997. It was from Lunden and Olson, and it was this study that looked at people who, it's called stops walking when talking. And so it was a study that looked at people who, when they started having a conversation, they stopped walking. And they found that there were increased fall rates in people who functioned in that way. So we know gait changes can be seen with cognitive impairment, in that fall risk increases with the severity of dementia. So the more severe the dementia, the higher the risk for falls. 70% of individuals with dementia fall per year, and people with mild cognitive impairment have 2 times the risk of falls compared to their normally cognitively intact peers. So we think that there is this relationship between gait and cognitive impairment, but we also think that they're independent risk factors for falls. So maybe they come together, but independently we know that they're risk factors as well. And so teasing this out is really where the science is at. So we have traditional medical mobility risk factors, and these are things like diabetic peripheral neuropathy, heart failure, arrhythmias. We know fear of falling can lead to this. Things as obscure, fortunately these days, as tertiary syphilis, but things we should still keep in our brains as potential medical contributors to falls. We know dementia, delirium, medications. All of these things contribute to fall risk and mobility impairment. And so there are medical risk factors for impaired gait. However, the loss of the central processing of all of this input coming into the brain, so the loss of this ability to process this through mild cognitive impairment and dementia, seems pivotal when it comes to gait slowing and fall risk. A study from 2011 looked at gait speed and survival. And if you look closely in those who are 65 and you take a gait speed of 0.6 meters per second, the median survival in terms of years for that group was about 12 years. Now, if you increase that to 1.1 meters per second, the survival is about 20 years. And if you increase it to 1.5 meters per second, the survival in men is almost 30 years. You can see over time, obviously, the length of survival decreases as they age, but that relationship remains that those who are quicker walkers and remain over 0.6 meters per second seem to do better, and that is both for men and women. So mobility, mild cognitive impairment, and independence. This was just recently looked at. It was published in the journals of gerontology. And this was a study that was looking to assess outcomes of a population, and they looked at 2 groups. So they had normal cognition and mild cognitive impairment. And then each of those groups was divided into 3 subgroups based off of gait speed. Okay? And they evaluated mortality and loss of independence kind of in those 6 groups. So looking at 5-year survival in these groups, if you look in the top left, those who had good mobility were walking quicker than 0.9 meters per second and had no cognitive impairment. 70% of them went on to live the next, after 5 years. What's interesting is the people who didn't have cognitive impairment but had slow gait, less than 0.6 meters per second, only 23% of them went on to survive beyond 5 years. Now you take those with mild cognitive impairment, that's a big step down, but it still declines in the same fashion in terms of longevity based off of gait speed. And so those who have poor gait speed, less than 0.6 meters per second, but also had mild cognitive impairment or dementia, only 11% or 11 people out of 100 survived beyond 5 years. Now the next portion of this study was of the survivors. So take those who had a poor gait speed, who had dementia with mild cognitive impairment. Of those survivors, of those 11, take that as now your new 100%. How many of those individuals were still living independently at 5 years? And only 25% of those who had a low gait speed and mild cognitive impairment or dementia were still living independently at 5 years. And so if you think about that as a starting group of 100 people, that means roughly 3 people are left independent in surviving out of that initial 100. So we think that there's 2 things at play here. We think the mild cognitive impairment certainly has some contributing, but gait speed certainly seems to be having a role here then as well. And we can see the same sort of survivorship with gait speed in the non-cognitively impaired. And so we think there's a dual role and an interplay between the two. Then there's several studies, I'm going to go through two of them, that look at this idea of dual task studies. And so these are studies that have people ambulating, walking, while they're simultaneously doing another task, a cognitively arduous task. So maybe it's remembering a story. For example, in the upper left corner, they did short-term immediate recall on a short story. And then they did delayed call of that story then as well. In the bottom right, it's a trails making test where individuals had to walk a certain path. Or an example of a trails that you might do in clinic is connecting dots. So complex trails would be connecting letter A to number 1, then to letter B to number 2, and it's this alternating number letter pattern progressing. And so what they found with this is that their control group did okay, but the slowed gait and mild cognitive impairment group did worse with performance, but it was the mild cognitive impairment group and the slowed gait group that did worse universally when they tested all these different areas of attention and visual, spatial, and executive function. And where it's really pronounced and seen is in the trails making test in the bottom right portion, where the slowed gait and mild cognitive impairment group performed similarly, but it was the mild cognitive impairment group with slowed gait that performed far worse than they should. And so this is a study from 2015 that, again, it's an evolving science here. And so what do we know about this? So it seems like mild cognitive impairment with slow gait had worse cognitive function across the board, regardless of the domain. They had higher risk for falls in those who had both mild cognitive impairment and slowed gait, and this group did worse than those with mild cognitive impairment alone. This study suggests that gait and cognition have a common pathophysiologic pathway or deficit, because it's this idea that when this area of the brain, this executive and attention area of the brain, is needed for gait control, and it gets bombarded with other stimuli, that then both performances are decreased. So we see slow gait with deficits in any of the domains of visual, spatial, processing speed, attention, executive function, and memory domains. All 5 of those were tested with this study, and we see deficits in gait speed, or performance really, with any of these areas. So this was a study done by Montero Odesso, which was another dual task gait evaluation in individuals with mild cognitive impairment. And Montero really seems to be at the forefront of this. And so what they looked at, what his group looked at, was gait speed in the control group, so those without cognitive impairment, and then gait speed with those with mild cognitive impairment. And then they gave them distractions or distracting tasks. And so they had one of those tasks was naming animals, the other task was serial sevens. And you can see that the control group performed better than the group with mild cognitive impairment. But the step off and the difference between those two groups, there was one, but it wasn't that substantially different from one test to the next. They seemed fairly similar, that amount of step off. What they also were measuring, though, was gait variability. So what gait variability is normally we're very rhythmic with our gait, right? It's okay. Now, if someone does have, let's say they have arthritis of their hip, where they have a longer swing phase on their affected side, there's still going to be a normal pattern to it, even though the swing phase might be longer or slower on the affected side. There's still going to be a pattern to it. And so what they're looking is variability with that swing phase, with the step height, and with the rhythmic nature to that step. And so what they found was the group who had mild cognitive impairment had more variability as they added tasks into what they're asking them to do. And this is seen with this graph. So this is really looking at the difference between those two groups. And if you look at the graph on your left, you'll notice a p equals 0.23. So that's a p-value. And a p-value tells you the likelihood that this result is because of randomness. And you want that p-value to be less than 0.5 in order to demonstrate significance. And so gait velocity doesn't seem to have any statistically significant difference between the two groups. However, gait variability is where there was statistically significant difference. And so what the thinking is that gait variability might be more sensitive for identifying mild cognitive impairment. And that variability may be a good predictor for falls, even in people who have an otherwise normal gait speed. And it's really through this idea of doing dual task testing that you can really pick this up, because a gait analysis alone won't pick up this variability. So high gait variability, what it represents is it represents gait instability. And it's because the higher levels of the brain are having to compensate for these inputs that are coming in, and it can't compensate like it used to. And so it's seen as gait variability. So how does this all come together? So let me try to bring in frailty a little bit, because I spend a fair amount of time discussing that. So let's look at those who are cognitively frail. So these are people who have mild cognitive impairment or dementia, and then they also screen positive for frailty. Okay? And so what they're trying to do is, in these cognitively frail people, is seeing if they can identify if this is a risk factor for dementia. And this is a study from 2016 from the Gait and Brain study from Ontario, there with Montero. And so they did the cardiovascular health study frailty evaluation, which is the FREED, or the frail phenotype, with a Montreal cognitive assessment. And then they compared the individual components of frailty of the phenotype to dementia outcomes. So they looked at weight loss, for example, on its own, separate from frailty. And they looked at gait speed, separate from frailty. And they looked at activities of leisure and calorie expenditure, separate on its own. And on this chart, again, looking at p-values, the thing that seems to stand out is that slow gait seems to be the predictor for future memory problems, and not frailty alone, or not frailty as a group, but gait speed by itself. With cognitive impairment or with normal cognition, that's where it seems that it's the slow gait seems to play out for risk of future dementia development. So gait speed was the significant predictor of future dementia. Frailty was not. Current cognitive impairment and the other four components of frailty were not predictors for dementia. So there may be two different physical signs of the same pathophysiology, is what the thought process is, that we're seeing decreased gait speed, impaired mobility, we're seeing memory problems, but really, is it all because of this issue with central processing? That remains the main question. So if you think about gait in the upright walking position, anything can disrupt it. Musculoskeletal pathology, motor slowing, motor recruitment issues, disequilibrium or poor neurological sensation, cardiovascular issues. But it's this loss of central processing and loss of coordinating these movements that seem to have an impact as well, that needs to be considered and further studied. This is a schematic of a fall, and this is from Journal of American Geriatric Society, January 2018. So fresh off the press. And in the top right, or in the kind of the side right, strategies for modulating or modifying risk for falls. So you need executive function and attention. You've got sensory input, so you got your visual input, you got your vestibular system, and then your somatosensory. And so your visual is looking at the horizon and making sure that it's level and not off kilter. Your vestibular system is kind of your gyroscope, as I described to my patients, tells you kind of how you're moving, where you're moving, and in what direction you're moving. And then your somatosensory. And so that's your position sense, and it's knowing where in space your great toe is and how flexed it may be and how much pressure it's feeling because of contact with the ground. And it also gives feedback with knee position, hip position. And so your body is taking all this sensory input and it's going through the motor cortex and it's going through this executive function and attention issue to be able to pay attention to where things are and where they're at in space and then process what that means. And then if we put into, starting at the left then, the schematic of the fall. So the person who's walking who feels that they're going to start falling, okay, what happens is the trunk becomes mobile as the first step, and the hips and ankle, they become firm, they become fixed. And the reason that is because the hips and ankle, that's your base. And so the base becomes stable. And the center of gravity is in the trunk and pelvis. And so you start to try to find the center of gravity above the base. Once that fails and the fall continues and the motion continues towards fall, then the trunk becomes stable so that now your center of gravity is fixed and the ankle and hip become mobile, trying to change, and that's where you see people trying to catch themselves with their feet. And that's trying to get the base under the center of gravity. And then, once that fails, then it's putting the arms out trying to catch, trying to disperse the weight as it hits the ground. And you need attention. You need executive function to modulate this whole system and take all the input in from this system. And when those are lost, then what we see is more severe falls, more severe injuries, because instead of falling in a semi-organized fashion, yeah, they still fall, but they can kind of break their fall. Now they go down like a sack of potatoes. And more substantial injuries for these individuals because they can't modulate their fall. And so I think this is a very good schematic for laying this out. Again, this is Montero's work, but a very good schematic for understanding why these higher level brain functions matter for fall prevention and mitigation. So I leave you with this. Mobility is not simplistic. And we're going to talk about a number of different areas of mobility and why it's relevant, but it's not simplistic. And cognitive function seems to play a key role in regulating walking and preventing falls. Walking is not automatic. You think about what we ask our bodies to do. I mean, I'm a size 8 shoe. That's tiny. That's a tiny footprint considering how high my center of gravity is. And so it takes a lot of organizing and structuring and complex thoughts behind the scenes to organize what our bodies to do with that. So it's not solely because of musculoskeletal and sensory dysfunction. The brain motor control plays a central role in this in terms of gait, balance, control, and fall prevention. And early dementia changes could alter this ability for normal gait and fall prevention. And maybe it's in looking at gait and falls as our early indicators for dementia. And which comes first, we don't know exactly, but the interplay seems to be there, and I think we should clinically pay close attention to it and think to ourselves that maybe if someone's falling, maybe doing more assessment beyond monofilament testing for sensation, or doing a pharmacy assessment for polypharmacy and contributors to falls, but maybe also screening for memory might be an important piece here in screening for memory moving forward too, because they may not have it yet, where it may be subclinical. And keeping a close eye on these individuals. I'm not taking away how medications and comorbidities play in this. I think those are important because they affect this whole system. But don't forget about dementia and its role. So our learning objectives. Identify frailty. Hopefully you feel confident doing that. Treatment and clinical implications of frailty. Again, I hope you can see those and how they're relevant. And then hopefully you start to see this interplay and this relationship between cognition and frailty. I think it's very complicated, and it's in its early stages of research, but it's an exciting time, and I think it's going to be interesting to see what comes of all of this. Here are the major references that I used. I've done a lot of reading on these topics, and I thank you for your time, and I hope that you can get a lot from these sessions. I think it's an exciting topic, and the research from these topics is only going to grow in the future. Thank you for your time. I hope you enjoy our series.